Good afternoon, everybody. Welcome to our monthly meeting for our community practice with Social Prescribing USA. I'm Jen Kuo, Programming and Education Lead. And today we have the great pleasure, really excited to have our presenter today, Dr. Elizabeth Markle, who is the Executive Director and Co-founder of Open Source Wellness, a 501c3 nonprofit based in Oakland, California. And Dr. Markle is here to share with us today their unique community as medicine approach, which incorporates health coaching that complements social prescription in the areas of nutrition, physical activity movement, social connection, and mindfulness. So let's give a warm welcome to Dr. Markle.
Thank you so much, Jen. I can feel the warmth. Thank you all for being here. Again, I'm Dr. Elizabeth Markle, but everybody calls me Liz, and I hope you will as well, and that this can be conversational. We're all working here together towards the same goals, and so looking forward to hearing about the intersections of our work. I am a psychologist by training. I'm a professor of community mental health at California Institute for Integral Studies, and my journey into this work started right around 2014 when I started doing integrated primary care behavioral health, which is a whole lot of words for being the mental health clinician that was embedded in primary care clinical groups, both in giant medical systems and in tiny federally qualified health centers. And I had the opportunity to observe a lot of healthcare appointments happening. It was part of my job to provide motivational interviewing training to medical residents, which is an exciting and sometimes challenging task. But during that time, I got very interested in what I now call behavioral prescriptions. And I'm going to pop my screen up here so that I can give you a little bit of a visual on this. Yeah, here we go. Behavioral prescriptions are when a provider or a therapist or a case manager says something to somebody like, you should exercise more, or you need to eat better, or you should reduce your stress, or even something like you need some social connection or some meaningful support in your life. Now, I think everybody on this call would agree that these are fundamentally good advice, right? They're directionally correct. We would all agree that these are some foundations of human well-being. The problem is that in the clinical systems that we all grew up in, these verbal prescriptions are delivered at the end of a very rushed, quick visit, and as somebody's going out the door, and then the provider says something like, all right, then, good luck with that. Take care now. I'll see you in 6 months. And that's the end of the conversation. And I want to be super clear that I am not provider shaming here. This is not the provider's fault. They are doing the very, very best they can with the schedules they're on and the resources of the systems that they have. However, this is a model with gaps, because we would never tell somebody like, you need antibiotics, good luck finding them, or you should try some antidepressants, take care now. We have a whole delivery system, the pharmacy system, for helping people with those kinds of prescriptions. The second problem that I'm aware of is that we have an equity problem, because for patients with privilege, whether it's financial privilege or social cultural privilege, they might take this verbal prescription and start shopping at Whole Foods or join a Pilates studio or hire their own health coach, all of which is great. But for the patients who need it most, this is a prescription to nothingness. And so, we could talk more about this if we had more time, but sometimes I think these prescriptions to nowhere are actually like worse than neutral. They're a setup for someone to feel a feeling of personal failure and even shame when they say, yes, doc, okay, I'll try. And then they go back, and then the life that they live doesn't support this. And their chronic progressive conditions worsen, and we see them in the emergency department, and they feel like it's their fault. Like, oh, I just didn't have the willpower. I just didn't try hard enough. And that is a way that our system is not doing no harm. That's a way that we are generating harm. So all of that is to say, in 2016, along with Dr. Ben Embert Aronson, we co-founded Open Source Wellness as a nonprofit. We're based in Oakland, but our mission is now national, to create community as medicine, partnering with communities and healthcare to deliver joyful, trauma-informed, and culturally relevant programs for health, well-being, and human connection. And this model, over the last now 8-9 years, that we call Community as Medicine has really evolved based on our work with participants and the clinical systems, particularly the federally qualified health centers that we built this with. So it is an experiential, and I'm going to keep coming back to that word, equity-centered, trauma-informed, and joyful approach to group health and wellness coaching. So if you think about group health and wellness coaching, you probably have an image of maybe chairs in a circle, or people are on Zoom and they're talking about their health. And in some ways that's accurate, except the word experiential. And so our commitment is that we don't just talk about these things, we do them together. So those 4 icons that you see in the middle of the logo there represent our universal prescription, which we abbreviate MOVE, Nourish, Connect, and Be. So that's physical activity, healthy nutrition, social connection, and stress reduction. And what it looks like in practice is human beings coming together for usually between 60 minutes and 2 hours for 12 weeks, once a week. It might be in person, it might be virtual, it might be in English or in Spanish, it might be in the clinical setting, right in the conference room, or it might be in the community, and actually practicing those 4 things: move, nourish, connect, and be. And I'll be candid, as we have built this model, we started off just demonstrating it. It's led by health and wellness coaches. We do a lot of training for board certified health and wellness coaches. And one of the earliest innovations we figured out in 2017 was how to deliver this model as a group medical visit. So the health coaches lead the program, but one primary care provider participates in the group and pulls patients aside for short top of scope visits. And in federally qualified health centers, the reimbursement rate for those short visits is high enough that you generate more revenue than it costs to bring this program in. And so being able to do this in a revenue generating way for these clinics that tend to be pretty under-resourced was a major victory for us. And we're still doing that to this day. I want to name that healthcare tends to be pretty siloed. I can't tell you how many clinical administrators and systems developers have said, like, well, wait a minute, this is cool, but is this chronic disease prevention? Or is this mental health? Or is this like social needs? Like, wait, where does this go? What bucket? And we have pretty staunchly said it really sits at the intersection of them. And regardless of what department holds this work, we're really, really looking at all the ways that physical health, mental health, and social health are deeply, deeply intertwined. And so in this model, we don't have groups for people with depression and groups for people with diabetes. We have groups for humans who, as far as I can tell, everyone on this call has some strengths in their well-being and some challenges in their well-being. And in a community as medicine group, we might have different primary diagnoses or a different thing that hurts the most that day, but we're training the coaches to lead with sort of a trauma-informed, culturally relevant, humanity-first approach that lets us see the commonalities in that we are all working together to care for our well-being, and we do it better in community than we do it on our own. We've been doing this, like I said, since 2016 with a wide variety of partners, ranging from tiny federally qualified health centers to bigger systems like the YMCAs. We do this work in partnership with food as medicine programs. Here in Alameda County, the Recipe for Health program is a really strong partner that provides a food pharmacy, that's doorstep delivery of produce, with what we used to call us the behavioral pharmacy, right? We're helping people with behavior change, and then provider training on how to clinically use food as medicine as part of the intervention. So that has been a really exciting sort of growth path for us. I'll say just a little bit about our patient population before talking about outcomes data. This model was sort of built out of the federally qualified health centers, which are the clinics that receive federal funding to serve everybody, regardless of their insurance status or capacity to pay. And so this model was built around the needs of a very, very diverse population. And we've since done this work with corporate communities or educational communities or clinical systems that are serving a slightly more privileged patient population, but this is really where we started. Of course, somebody will ask the question, well, does it work? How do you know that this creates change rather than just cute pictures? So we've been tracking data from the very beginning. My co-founder's a statistician and he loves this. So I'll share just a little bit with you. This is a sample of about 750 patients coming from the clinics named at the bottom. And we're seeing a significant increase in daily intake of fruits and vegetables, weekly minutes of physical activity. For our patients who are struggling with mental health challenges, we're seeing massive drops in depression as measured by the PHQ-9, anxiety by the GAD-7, and loneliness by the UCLA 3-item loneliness scale. Some of our patients are struggling with hypertension, and we're seeing drops in systolic blood pressure. And then the data that, of course, gets the attention of our payer partners is around reducing emergency department visits and unplanned hospitalizations. Now, this is a smaller sample. This is not a randomized controlled design, but I think it merits naming that this is kind of what we have the potential to see. So I'll say a few more things, and then I want to just open this up to conversation. One of the things that we do at Open Source Wellness is train individuals who want to become health and wellness coaches. Health coaching used to be an unregulated term. Anybody could declare themselves a health coach. Now we have the National Board of Health and Wellness Coaches that accredits and then has a certification exam for health and wellness coaches. And we are one of those accredited programs. And we are really training people. It's all virtual and mostly live to embody these principles of cultural humility and being trauma informed and thinking about leading groups in their coaching, not just one-on-one. So we offer those cohorts twice a year. We just started one in February and one will, I think, start in August. And then for organizations, we help them build the capacity to deliver community as medicine themselves. So this takes the shape of what we call the Community as Medicine Learning Collaborative. And part of what we've learned is that just teaching one or two people how to deliver CAM, as we abbreviate it, Community as Medicine, doesn't necessarily generate a financially sustainable model that will endure within an organization. And so each of these little hexagons represents the sort of the work streams or the buckets of focus within this learning collaborative that organizations need to build, like the data and analytics, the financial sustainability, the referral partnerships and pathways to really have their Community as Medicine program thrive. So in 2024, we had 4 organizations go through it. In 2025, we have 6. They range from YMCAs. We have a lot of YMCAs. We have, let's see, Tampa General Hospital. We have a fully Latinx-focused community-based program that's out of Redwood City. And we're so excited to be building the evidence base nationally. This cohort has folks in New Hampshire, Florida, Maryland, North Carolina, and California, I believe, to round out the Denver and Minneapolis team that we had from last year. So we're excited. It's a lot to do. And yeah, I think at this point, I'd love to just open into conversation. I have not been monitoring the chat, so maybe I'll pull down my slides, take a look at what's happening here, and would love your thoughts and questions.
Thank you, Liz. We have one question so far from Serena. What resources do you recommend for learning more about the economics of social prescribing, especially those reimbursement models that allow under-resourced clinics to make a profit?
Yeah, man, if somebody was an expert in this, they'd be busy for a decade. I want to say I'm not an expert in this. I don't come from healthcare policy, but I've had to learn some things along the way. So there are a couple strategies that we can use. One is the group medical visit strategy, where you say, okay, we want to deliver a program, and the program could look any number of ways. It'd be staffed by any number of people. But if you have a primary care provider who's participating in the group, and whether they're sort of seeing the group as a whole or doing individual pullouts, they are generating billable encounters. And if you take a primary care provider's baseline productivity rate, which might be 3 or 4 patients an hour, might be higher, might be lower. Yeah, Alan's got this handled. and you can do better than that in a way that covers the cost of the program, that's a shot at creating access for people who aren't going to pay privately. Another strategy is using community health workers in the places where there are reimbursement pathways for community health work. Another pathway is to tag your social prescribing service along with something else that's getting funding. So for example, food as medicine is being funded here in Alameda County where I live. And so a lot of our local patients, their participation in community as medicine is funded because it's paired with the food. And so the payer is paying for the food, and we've called this nutritional and behavioral supports that go with the food. So it's a little bit of a sort of a creative bundling of things in a way that the payers will recognize. Alan, I'm so interested to hear what you have on this topic.
I know. I just did these groups, did a bunch of group medical visits for, I don't know, 11, 12 years when I was working at FQHC for Contra Costa. And that is exactly what, as Liz says, it is potentially a way you can bring in money, because instead of doing clinic, I mean, doing groups is so much better care just from the get-go. So if I could do groups all day, I would. At one point, I got up to 3 groups per week, but anyway, it didn't get sustained. But anyway, for FQHCs, it's a special thing where they can really bill as a normal visit, and that's a sustainable model. As long as you have the number of patients that you see in a half day, you can generally rationalize that you're doing good work. And then what's great about groups is you can kind of bring whatever you want into the group. And so there's a lot of great stuff that can happen once you're in a group. I just wanted to say that I got to attend one of Liz's groups, and in case you can't tell, it's a pretty special experience, and just a lot of great things happening in community building and mindfulness and the individual coaching that happens in small groups and all that. It's just a great model, and yeah, with a great outcome. So I highly recommend the work that Liz is doing.
Thank you, Alan. I want to say one more thing about groups, and then Brittany, I want to hear your question. So many of the group medical visits I've seen in FQHCs require and rely on a heroic primary care provider, somebody like Ellen, who is beloved by the patients, who's going to call them, text them, track them down, who's charismatic, who is like a meditation teacher and a Zumba teacher and a vegan chef. And I don't know what, right? They just do it because they love it, and they build all these capacities, and it works great until that person burns out, or that person goes on maternity leave, or the clinic says, actually, we need you in this other place, and the whole thing falls apart. And so part of my quest has been, let's get the group anchored by coaches who are affordable, who have the cultural competence and the linguistic competence, and who can hold the relationship so that if the provider needs to be swapped out, they can. And it's not like the end of the world because the group is held down by professionals who, that is what they do. Okay, rant over. Alan, did you want to say anything else?
No, I agree. I think we were able to bring in other things because we had our hospital foundation who was willing to support things. So I think that really trying to think about sustainable models is just the key to all of this work. But
yeah,
it's good work. So it somewhat sustains itself until your organization decides they don't want group visits anymore, and then it's all gone. So yeah, so it is really important to just figure out sustainable models.
Yeah, amen. Okay, Brittany, what's on your mind?
Thanks so much for the presentation. As someone from the YMCA, my ears are burning as you're saying YMCA. I don't believe that my current association is currently looped in with you, and I don't want to kind of monopolize the conversation. So I just want to ask, would it be okay if I reach out to you offline to kind of have a better understanding of how you're partnering with different Ys?
Absolutely. Can I ask what your association is?
Absolutely. I'm in the Greater Nashua, so up in New Hampshire.
Or Nashua. Okay, yeah, we are partnered with Granite Y, and
Okay.
Cindy LaFond is the person to talk to there if you want to chat with them. But yes, please reach out. I'll just stick my email in the chat.
All right, fantastic. I appreciate it.
And if ever I can't respond to you, I will route you to another team member. Sometimes I get a lot of emails and I'm not the right person, but feel free to reach out.
All right, thanks, Liz.
Yeah.
Okay, so we have about 6 more minutes that Liz can, before Liz has to hop off. Sherry asked in the chat, I haven't heard very much info on nutrition the mix of social prescribing programs. Any thoughts on this topic being left out of most of the social prescribing models? Can they still be as effective without this topic included?
Yeah, and this is such a great question. And Alan, I hope you can chime in here as well. I feel like everybody has their own imagination of what social prescription is, right? Like some people are like, it's art museums, and some people think it's nature, and some people think it's dance classes, and that's what it is. And we've gotten the question, are you really doing like more clinical care than social prescription? And so yeah, Alan, do you want to chime in on sort of like how do you understand the maybe overlapping tendrils of mental health and social support and chronic disease care? I mean, my stand is always that they're so interwoven that it almost doesn't matter what the front door is, that the active ingredients need to be the same. But what's your take?
Yeah, I think think similarly about it is that, I mean, even the person who does the most groups in the country, his name is Jeff Geller, he's basically said it really doesn't matter what you do in the group, do a group. Like you don't have to actually have a theme. You can ask the group, what do you want to do? Like it's just that powerful to join people in a community. So I don't think that there's any necessity that you do a certain thing such as nutrition. I think that, if you do the arts, if you do, I think there's just a lot of things you can do, go walking out in nature, just bring in all the various tools. I did a program called Walk with the Doc where we took people, educated them at the clinic, then bussed them out to regional parks. I brought in expressive arts therapists to work with them and musicians and a naturalist and Zumba and yoga. And I don't care what worked, but something worked. So I think going multimodal where you try different things is just that much more powerful because I don't know which one of them is actually doing the thing. But if you have opportunities to mix it up, I think that can be really powerful. Things like music in nature or things like that are just really just powerful experiences.
Yeah, it's a powerful statement. It doesn't matter what you do. I think for some populations it does matter, right? Like if you're newly diagnosed with diabetes, you need education about what's going on there. And if you need to make a massive shift in your diet, then you need that kind of focused education and coaching. And many people need social support. They need a holding environment where they can do the work on their well-being. And to have some of those active ingredients like the dissolution of shame, right? The normalization of like, oh, I'm not alone in this. I haven't just failed. Like this is the human experience. We struggle with our well-being and we can talk about it and we can provide accountability and empathy for each other. So I think that's the heart. Ivory, please.
Yeah, I have a question on outcomes, but I just want to quickly just kind of respond to Sherry's question. I think it really depends on the population that you're serving. And if you're teaching cooking classes, but the people don't have access to food, then obviously that needs to be addressed. So I think it really depends what the needs and the goals are of the clients. So my question is the outcomes that you shared, are those taken at the end of the 12 weeks? And if so, what is like the follow-up for seeing how they've sustained these behavior changes 6 months, a year later? What are those prolonged outcomes?
That's you know what? I'm meeting with my co-founder at 1 p.m. Pacific to talk about whether we're going to revive our 6-month follow-up data initiative. So we have some research partners that are doing that, but we want to be doing it internally as well. Yeah. There's a great question, Deborah, about whether the health and wellness coach is the same as a link worker. So there are folks who use the phrase health coach very loosely, like the word counselor gets used very loosely, but it's different from a licensed therapist. I think health coach is becoming that way, that nationally board certified health coaches have gone through a curriculum that's about 80 hours of live training and skills assessments, and they're passing a national exam that's pretty challenging. And they've really demonstrated some competence, which, as I understand it, is not the same for a link worker who could be someone who's trained to be empathetic and to provide resources and help link systems together, but they're not necessarily a health and wellness coach. You could have health coaches serving in a link worker capacity, but it doesn't necessarily go the other way. Okay. Nicole, sounds like a very cool group that you run. Anything else that I missed or that is left over?
Yeah, before you hop off, Clarissa asked, any tips for connecting with organizations to bring this wonderful work? Where to start?
What a great question. So if you're an individual, Clarissa, are you sort of an individual and you're saying like, how do I plug into a group? Is there anything else you want to add to that?
Well, I'm an artist actually, and but I also incorporate movement in my work. And I was just curious, and I have approached like my previous employer because I kind of did something similar to you, where I was a motivational type of person for the dental field. But I was just curious if there's anything more you could share about just starting that conversation with
Yeah.
with other organizations about this.
Yeah, such a great question. Well, there are always informal pathways, right? If you are running a program and you don't need a lot of financial support for it, you can build relationships with clinicians, with therapists, with social service folks, with case managers, and say like, hey, I'm offering this. How could I get this as part of your research, your referral pantheon of things? And that is sort of like, if somebody's excited about your work, they may mention it to people or give them a flyer or something. But that would be like an informal, no payment, no tracking, no organizational partnership. And then the organizational partnership is always what takes a little longer, especially once you start things like sharing data and compensation. And for that, it helps to be part of an organization that has a model and can sort of operate in a HIPAA compliant way and create outcomes data and all of that. But it all starts informally. Like we started by saying, we are going to run this group every Tuesday night. And we basically begged federally qualified health centers to send us their patients for free so that we could try to demonstrate outcomes to make a difference. And so it really sometimes starts very organically. Alan, or would
Yeah,
anybody else?
I would
Yeah.
just jump in that almost everything starts from having a champion. So just find someone inside the organization who is excited about this. It's probably helpful if they're in the clinical realm because I don't know, they can sometimes push things to happen. But I would say just really find one person you connect with who can really champion this through the organization, because I think that's where the energy for these things happen.
Thank you.
There's also a field guide for social prescribing field guide, if you haven't seen it, to kind of give you ideas about how to get together the different stakeholders that are needed to do these things. So definitely check it out.
Well, thank you so much, Liz, for your time and your passion in this work. We look forward to following open source wellness and seeing all the incredible work you guys are all doing over there. And Liz dropped in her email in the chat. This will be on playback on a YouTube channel and also be highlighted in our next newsletter. So thank you so much, Liz.
Thank you so much. It's wonderful to be with you all, and don't hesitate to reach out. Have a great rest of your time together.
Thank you, Liz.
Bye.